Here's nothing. So tonight, I just want to say thank you to everybody who's been participating over these last 8 weeks. It's been a lot of fun for all of us. This is our last divisional topic. The trauma division we featured last. Dr. Seth Yarboro, who's one of our traumatologists, will be speaking on ankle fractures tonight. And so I think there is going to be some time for a little bit of interaction during the case presentations. I'm sorry to inform you that our trauma service is still actually active in the OR. So our chief resident on trauma, Eric Larson, is probably knee deep in an acetabulum right now. And Nicole Quinlan, who's our PGY-4 on trauma, might be there as well. So we do have some good fill-ins. Max Hoggard and Michelle Kew are here to fill in in case we need them. But without further ado, I'll introduce Dr. Seth Yarboro, my good friend of the trauma division. He's going to be talking about ankle fractures. All right, Seth, take it away, my friend.
All right, appreciate the intro. So this is not a comprehensive talk on ankle fractures. Really, to fit it into 20 minutes couldn't pretend to be. So some of the things I tried to focus on were aspects maybe of ankle fractures that I didn't understand until a year or two later than I wish I had. So if you could take a few pearls away from it, then this may be time well spent. So just want to mention about mechanism. So the title is rotational ankle fractures. And I think that's just important to distinguish from an axial load kind of injury, the distal tibia pilon fractures. And these certainly exist on a spectrum. You can have rotational ankle fractures that have impaction or an axial load component to them and vice versa. So really thinking about where on that spectrum they exist and recognizing the difference in those two. So just to complete the images for this patient, there's a lateral view, fibula fracture that's above the level of the joint, displaced medial malleolus, lateral translation of the talus, and something going on the posterior malleolus. So when I get a call about an ankle fracture, the things I really want to know, usually age is in the one-liner. That's nice to know. Mechanism, how does it happen? You may have a lot of insight from the mechanism based on the x-ray. Medical comorbidities, so what are we going to be up against if this patient needs surgery? And then functional level or their occupation. So is this a high-functioning person, somebody that has specific athletic pursuits? What's their job? What are they trying to get back to? For physical exam, really, what's the condition of the skin? Is there an open injury? Is this something that needs to be taken care of more urgently? And then what's the neurovascular exam? Sometimes the foot's kind of cold when it's at 90 degrees out of its normal alignment. And so specifically related to the neuroexamining, baseline neuropathy is important to know about. So from an imaging standpoint, really talk about three views of the ankle: AP, lateral, and mortise view. The AP is shown on the left. The mortise is on the right, and you can see the joint space is much better there, and that image is a little concerning for what's going on with the medial joint space. So really, anytime you can get weight-bearing views, it's nice to. That's usually not feasible in the acute fracture setting or the acute injury setting, just because weight-bearing would be too painful. And then get full-length tibia films. So you want to see the proximal portion as well anytime. You know, for the fracture we have here, there's no obvious fracture, but there appears to be displacement, instability at the joint. You want to rule out a proximal fibula fracture, that Maisonneuve pattern. So back to reduction. So this patient has a displaced ankle fracture. They're in the emergency department. Michelle, why don't you tell us, Michelle Kew, one of our chief residents, kind of the steps you'd go through for hematoma block. This patient needs a reduction and splinting, and maybe you could talk us through that.
Yeah, sure. So when you see a consult in the ER, I usually just start gathering all my supplies. And one of the things like Dr. Yarboro mentioned is stuff for hematoma block. You typically get 1% lidocaine for that. And I usually use about 10 cc, so getting a 10 cc syringe. I like to use 21 gauge needles. 18 is pretty painful for the patient, but any smaller, it's pretty hard to push through the small opening. So, and then when you get to the patient, trying to localize where you're going to put in the hematoma block. So entry to the ankle joint is medial to tib ant. And so that typically is a pretty good location for the hematoma block in a patient with an ankle fracture. And so you typically see tibant or feel it in a patient. And you can usually feel a soft spot right medial to it. So try and aim kind of parallel to kind of more plantar to kind of match the angle of the distal tibia. And then once you hit kind of interarticular, you can pull back, and if you see a flash of hematoma, that's where you insert your lidocaine. And then the patient usually gets fairly good relief from a hematoma block and just needs some further IV analgesia to help with the reduction.
Love it. So for this patient, internal rotation inversion maneuver was undertaken, and they had really nice alignment. So well-padded splint was applied, and then we had the luxury of figuring out a time to fix that fracture on an elective basis. So I just use this as a segue into talking about classification. So this one, there's the classically described Quigley maneuver, where you could almost roll the patient onto their side with the medial side up and hang their toe from a toe trap or finger trap, toe trap in that case. And that maneuver of internal rotation, inversion, tends to reduce these external rotation mechanism injuries. But as soon as you say that, then all of a sudden you've got to understand mechanism to decide who would benefit from that maneuver. So we'll just talk classification for a few minutes. And I'll be the first to admit, as a junior resident, I thought, well, you know, I'm willing to take my lumps. I'm just going to guess SER, and I'm going to be right most of the time. And I don't know, everybody seems caught up in these details, but it turns out it's really not that complicated. It's just nobody ever explained it in a way that made sense. So hopefully we can do that a couple of times between now and the end of the talk, and have time for questions. But the Weber classification, also AO classification, is all talking about the same thing. It's describing the fracture based on the level of the fibula. So Weber A is just below the level of the joint, typically an avulsion injury. Weber B doesn't have to be oriented like that. It could be any Weber B fracture, could be any fracture of the fibula located or starting at the level of the joint. And then Weber C is above the level of the joint. So that's not too complicated. Everybody kind of understands that one. And then you get this quick cartoon where then you say, well, here's how you convert AO or Weber classification into Lauge Hansen. And they got all these Roman numerals and they got all these pieces, and you're just like, all right, I'm going to just guess SER. But we can do better than that. So we've got 4 ankles laid out here, and then we'll just kind of use some of the PowerPoint cartoons to go through. So what does Lauge Hansen even describe? So the first part is the position of the forefoot, so supination or pronation. And the second word is the action or the movement of the talus relative to the ankle at the ankle joint. So supination adduction has the ankle moving inward, or the talus moving inward relative to the ankle, and the forefoot moves with it. So pronation abduction and supination adduction are both hindfoot and forefoot moving together in that same direction. You could think of those as more tilting. And so as the supination adduction injury occurs, you get an avulsion injury off of the distal fibula. So it tends to be a low fracture, avulsion. And then you tend to get a vertical medial malleolus fracture. I'm not sure if you can see my cursor. There tends to be impaction at the corner there as the talus drives up into the medial malleolus. Moving on. SER. So SER is most common, gets talked about a lot. This injury starts at the AITFL, the high ankle sprained ligament. And so SER1 starts at that position. SER2, as you continue to externally rotate the talus relative to the ankle joint with the foot supinated, SER, then you get this typical pattern that starts at AITFL and extends proximally and posteriorly across the fibula, and that's your SER2. SER3, I don't have it drawn on here, but then extends on around to the posterior side. So either tear of the PITFL or fracture of the posterior malleolus, and then SER4 extends all the way around to the medial side. And so there's 1, 2, 3 extends posterior, and then 4 gets the medial side. Pronation abduction, we're putting in the middle, and we'll go back to this. This is going to make sense. I know it seems like I'm just blowing through it for now, but we'll tie it all together and do it again at the end. Pronation abduction, we've said that the forefoot and the hindfoot are tilting together. So that's what those two words are describing. And so just the opposite of the SAD, the pronation abduction is going to fail in tension on the medial side, tends to be a little lower because it's a tension failure. And then because you've tilted into the lateral side, the fibula, you get a zone of comminution that usually starts at about the level of the joint. So this is why with that previous graphic, they're putting pronation abduction in the Weber B range because that typically starts at about the level of the joint. So same motion of the talus for PER as SER. It's just a difference in the forefoot being pronated. And so you can imagine pronation drives your first ray down. And so that tensions the medial side. So this injury starts on the medial side because that's what you've tensioned based on your forefoot midfoot position. You externally rotate, fail on the medial side. And the difference is that this tends to have a high fibula fracture. This is the pattern most commonly associated with a syndesmosis injury. So if all else fails and you think, well, that just sounds like a whole bunch of, tiny pieces of information that I can't tie together in any meaningful way, we put the Weber classification up. SAD is an A, SER and pronation abduction are Bs based on what we just described, and the PER is a C. So the mnemonic is, it's sad when you're served a Pabst and you think it's perfect. So if you can remember that, then all of a sudden, if you see a Weber A or you see that vertical medial side, supination adduction, SER and PAB are both going to be your Weber Bs, and then you're looking for those key radiographic findings, and then Weber C is going to be pronation external rotation. So we'll come back to that. We'll do that one more time at the end, and hopefully you can kind of think through it and use that on the case discussion. So who needs surgery? So if we disrupt the normal position, not even talking about malleolar fractures, but the position of the talus relative to the tibia, that requires a surgery. If that remains disrupted and can't be meaningfully maintained with a splint or cast. So the ankle has very poor tolerance for malalignment. We don't fix these fractures because they heal faster or because we like pretty x-rays. It's really because the classic study that a 1 millimeter shift in the talus relative to the tibia results in a 40% decrease in contact area between the superior and inferior cartilage. And so that results in increased load and increased wear and early arthritis. So it's really to minimize risk for arthritis by restoring that appropriate articulation. That's your indication for surgery. So we talk a lot about how do we sort out a 2 versus a 4. So we just talked about the 4 stages of SER. And so if our medial side has failed with a deltoid rupture, we got to know the difference between those two because that's important. And so this is your typical emergency room x-ray, the sort of ballerina pose, foot way down. You don't really know what to do with the AP. And so, it looks a little wide maybe, but also, the posterior aspect of the talus is more narrow. So when the foot's plantar flexed, it tends to make that medial space appear a little wider. So in thinking about how do we evaluate that, you can put your x-ray lead gloves on and go down dorsiflex external rotation stress view if you want, but you can also just get a gravity stress view that you'd set up about like this. And it's not a perfect science, but sometimes the answer that you get is a glaringly positive stress view. And so this is kind of an in-between that I bring up really more for to make the point about that it really is not perfect. We don't see much displacement of the fibula. The foot's kind of down. We still sort of get the sense, if you look at it from across the room, you'd say that medial clear space is pretty wide. And so I'd mentioned early on, weight-bearing views are great. If you can't get a weight-bearing view, sometimes the next best option is to get the foot in a weight-bearing position. So a plantigrade position where the foot would be flat on the ground. Well, all of a sudden you say, well, this is looking a lot better, and that person, now you've saved them a surgery. So for those that are in between, I really like to get them into the position that you would treat them in, and then you can make a decision based on that. We see minimal fibula displacement, and if we treated them with surgery and had that alignment, we'd be thrilled, patting ourselves on the back. So, I think that's a good indication for cast treatment. And you still have to follow them with x-rays, make sure that is maintained. If there's not any foot position, you could put this patient in that results in good alignment. So that patient's going to have surgery every time. And so just to show you what we did, fix the fibula anatomically, fix the medial malleolus. I like to use one long screw because it gets better purchase than short screws. And there's several studies to show equivalence between 1 and 2 screws, but that's kind of very much user dependent. A lot of folks still use 2 shorter screws, and that's perfectly fine. This patient had lymphedema at baseline, and so the posterior malleolus is there. You can see on the lateral view. You say, oh man, why didn't you fix that? That would have been a good chance to we'll maybe restore that normal articulation at the posterior lateral side, and we'll talk about that in just a moment. But for this patient, because of the additional exposure of the posterolateral approach and plating of the posterior malleolus, we opted for a transsyndesmotic screw, and that ankle mortise appears well aligned, and that's I think a very reasonable way to address that fracture. So talk for a few minutes about posterior malleolus size. We got a few minutes left. So 25% rule, people throw that around. Where in the world does that come from? Well, 1991 study from JBJS, they took a cadaver and then sectioned the plafond at these different levels, and they chose like common fractions, I guess you'd say, 25%, 33%, 50%, and they cut them off those different levels. They used contact paper to look for increased stress when they loaded the foot, and their conclusion was that the remaining contact area in various ankle positions was decreased compared to the intact specimen for all sizes, and thus the 25% rule was born. And I wish that was a joke, that's where this sort of dogma has come from, but that's it. So, you know, if they had decided 1/5 was a pretty cool fraction, then I guess 20% would have been the rule, but it was not. So I would throw the 25% rule out as having any real bearing for decision making. Plain x-rays are tough. You know, the example we just showed that maybe they're inadequate. We chose to put in a screw for other reasons, but when you're looking at posterior mal size, plain x-rays can be deceiving. External rotation views like shown here can let you better visualize the fracture, but that gets to our next point. So what about CT? CT changes the plan about 1/4 of the time, and then trimalleolar fractures, and then those that are above the syndesmosis with the fibula fracture are more likely to change as a result of the CT. So start looking at the posterior malleolus, you know, we're thinking about fixing it. A CT scan can be really helpful. So what's more important than the size based on whatever measurement, CT, plain x-ray, ballpark guess, is the morphology. So think about classification. These Haraguchi type 1 is exactly what you expect to see. It's a posterolateral clean fracture fragment, maybe has a bit of impaction at the fracture line, but that's the standard one, and that's about 2/3 in the Haraguchi series. Haraguchi 2 is the one that can be a little bit of a bad actor if not recognized, because that extends over to the medial side, can have implications for deltoid stability, and so you need to recognize that. And then 3 I would think of as almost like crumbs, you know, it's a cortical flake off the back and really nothing that could be reasonably fixed. So for posterior malleolus, it's probably the most important thing you're thinking about, whether it should be fixed and what's its size and, you know, how should we manage that, is the fact that the PITFL is attached to it. And I love how straight this line is, going across the oblique fibula fracture and then across the posterior malleolus, and these are connected by PITFL as shown in the cartoon. And so the advantage is, if you can fix the posterior malleolus, you do a couple of things. Is you restore the shape of your incisura so the fibula has a home to sit in again. It doesn't have 2/3 of a home. And then you restore the integrity with the strength of the posterior inferior tibiofibular ligament, which is probably the most important thing. So, you know, I like to say fixing the posterior malleolus is like calling your parents. If you think about it more than once, you should probably just go ahead and do it. And so this case is an example of, you say, oh my gosh, you know, some sort of pronation, external rotation, some variation on that at minimum, because the syndesmosis is gapped wide open when we look. There's a talus sitting in between them, so there's no way there's any intact ligaments for the syndesmosis. So we're thinking something of the pronation, external rotation variety. And I show this as an example of a CT scan. You know, you say, well, that's a small piece. If we even remember that the 25% rule ever existed, we wouldn't consider fixing that. And, you know, maybe that's big enough to go fix. But what we did was to pin the anterior lip and the posterior lip, because otherwise there's no incisura that you could put the fibula in to even know where it belonged. So we started pinning those. You can see, try to pin the fibula out to length. There's some significant comminution in the fibula. And then, you know, each side got a plate. So the posterior malleolus got a plate. The anterolateral fragment got a plate. And so as small as that was, I think we were still able to open it, see it directly, put a buttress plate on it. And then if you notice, there's no transcendesmotic fixation for this patient because that integrity has been restored. So it's really more about what are you restoring with the fixation, and what are you going to accomplish in terms of the anatomic nature of the reduction, that I think goes into decision-making for fixing posterior malleolus or similar areas for the ankle. So we'll do this one more time. So supination adduction, we're inverting, pull the fibula off with avulsion, that Weber A, so that's our Weber A family, and then vertical medial malleolus. SER, AITFL is where it starts, extends in that oblique pattern in the Weber B fashion, extends to the posterior side, and then as a 4 to complete, fails on the medial side, either through the bone or through the deltoid. Pronation abduction, tipping in the opposite direction of SAD, and failure on the medial side in tension, and then zone of comminution. Comminuted fibula is the hallmark for pronation abduction. And then PER, we tension the medial sides, we're going to fail there first, and then have a Weber C fibula. And there's your A, 2Bs, your C, SAD, and your cervipaps, and you think it's perfect. Thank you.
Seth, Dr. Yarborough, that was fantastic. I wish I had gotten that before I was a PGY-2. That would save me a lot of pain and suffering in fracture conference. Holy smokes. Yeah, I remember trying to memorize all those different Roman numerals that you described. And once you think about it conceptually, it makes it a whole lot easier. And so the beauty of orthopedics is that, you know, the biomechanics and the physics of it, you know, is pretty consistent. You know, it's a natural law. And so if you can just understand how it works, you can really understand, you know, one, how the fractures occur, and then two, how to fix them. So that was really good, Dr. Yarborough. Thank you. Just real quick, can you introduce the trauma service to us?
Yeah, so Dave Weiss, as you mentioned, is in the operating room, and he's my senior partner. So there's just two of us now, and we've hired Mike Hadid, who graduated last year and is in Denver for trauma fellowship, and will be joining us next August.
And real briefly, can you kind of describe kind of how our fracture room works? When I was a resident as a PGY-2, there was just a variety of different attendings who would cover all these fracture cases, but now the trauma service is much more mature than it was when I was a resident. So maybe just describe kind of how fractures are allocated.
We have, you know, barring some outstanding emergency, a dedicated room most days, every day, barring that emergency. And so are able to much more reliably start cases on time, have a plan going into the day that complements our elective cases. And so just having that control over the schedule has been a huge benefit, as opposed to coming in each morning and it being a bit of a circus at times in terms of trying to figure out who's going to go first and how do we get them sent for and how do we get the day started. So it has certainly allowed my blood pressure to be worlds lower, and yeah, it's a big improvement even during the time I've been here.
Exactly. So yeah, we do have a pretty robust trauma service, and honestly, you never really know when trauma is going to happen, but it happens obviously every single day. And so being able to think on your toes is important. That's why our trauma chief ends up being so important, because between the night float chief and the day trauma chief, they basically organize the entire trauma. I'd say that how they triage the patients, and they'll get the order in place, and they make sure the patients that are cleared can go. And ultimately, a well-functioning trauma service can take care of patients a whole lot more efficiently than the sort of haphazard one we've had in the past. So anyhow, I think Max Hoggard, who's our chief resident, currently I think on the adult reconstruction service, is going to cover for his friend Eric Larson, who, again, as I said, is probably in the middle of a trauma case right now. He's been texting me saying that they're I think they had 5 cases lined up today, and so I think they're on case number 4, so it might be a long night for him. So Max, are you there?
Right here.
All right, my friend, the floor is yours, but medical students, you guys, we talked about last time the hand raising option. Hopefully you guys remember how to do that. If you could, if a question does arise, if you could raise your hand, that'd be helpful. That way I can call on you. Otherwise, I've talked to a lot of you via Zoom over the last week or so, and so you might get a shout out real quick. So hopefully you raise your hand. So go ahead, Max.
All right. So I'll go through this stuff. I did not grow up in California. I did not match in a hand fellowship. That is not me. That's me. Let's get through some of this stuff. That mustache is horrible. Dennis wears midriff shirts, apparently. All right, so we'll get started. So this first one, some of these you may recognize from Dr. Yarboro's talk, but should make it easier to answer. So this is a 58-year-old, fell off a porch. Otherwise healthy person, was not a smoker. I work as a pet groomer. There's a picture of what the ankle looks like when you see them in the emergency department. And then that's the x-ray that you see. Let's skip this one.
What?
Since we talked about that one. We already did that one.
I know, but I mean,
You could ask some questions. It's called a warm up.
Go back to the X-ray, man.
Okay. All right.
Go back to the clinical.
We've got a lot of cases, but yeah, we can do it. Go ahead.
Go back to the clinical picture. I just want to make a comment on that. This
Yeah.
is what separates orthopedics from everything else. Because when that picture comes to the ER, like half the ER runs away, and the orthopedist runs to it. For me, I always thought that was kind of gratifying as an orthopedic resident, because this is my case. You know, you see that ankle deformed like that, nothing feels better than putting that ankle back in place. So show us that X-ray.
Okay, so
Who's out there who wants to try to answer this? Just describe it.
Describe it, yeah.
I see a hand raised. Matt Miller from Utah. Go ahead, Matt. Turn your video on so we can see you.
Sure thing. You guys hear me okay?
Yeah.
Okay.
Yep.
So looks like we got an AP, oblique, and lateral of the ankle here, skeleton mature individual. Looks to be like a trimalleolar fracture. You can see kind of the medial malleolus here has been avulsed, as well as this fracture in the fibula, and then there's the posterior fracture as well. And yeah.
Can you try to put in that classification Dr. Yarborough discussed?
I'm still struggling with that classification. Based on how high this is here, I would say it would be considered a Weber C, even though there's more involved because it's above the syndesmosis. Ankle stability is gone, so I would say it is an operative fracture due to the loss of the stability from the medial and lateral malleolus, as well as the posterior.
So just based on SAD, served, PAPST, and perfect, if you said Weber C, what must it be?
SAD. No?
Other direction, opposite end. That SAD was the A.
I'm having a hard time with this one still, Dr. Yarborough.
No, you're good, man.
It's okay.
So 2 quick feedbacks. That middle X-ray is an oblique. They also call it a mortise view. And then 2, even though that fracture looks really high, and actually, where does it start, Matt? Where do you think that fracture starts?
I mean, it would start down here inferiorly.
It starts at the level of the syndesmosis. Would you agree?
Mm-hmm.
Okay.
All right. Awesome. So these are your post-reduction films in a splint, like we showed. Status post hematoma block. Pretty good alignment. So if you look, if you compare middle X-ray here to the middle X-ray here, so the 2 mortise views that Dr. Gwathmey talked about, you can see this looks pretty symmetric, looks pretty nice. So it's overall really good reduction. And so like you said, Matt, clearly an operative fracture based on kind of what we know about the pattern, the mechanism, and the displacement that you can see there. And so there's the construct that we looked at earlier.
Cool.
Looks pretty good. So fibula is out to length, restored anatomically.
Thanks, Max.
Yeah.
Oh, Max, it's okay to trash the X-ray. I'd be like, I don't know what the attending was thinking on this one.
Way off.
So syndesmotic screws there to restore the stability of the syndesmosis, and then like Dr. Yarborough mentioned, a single screw for the medial malleolus there. So, so that was a good case. Now we'll go to some I think we probably haven't seen yet. So this is a 68-year-old male that was involved in a motor vehicle collision, head-on MVC. So a little bit different mechanism than just falling down the stairs like the last person. And so they have a right medial ankle wound, okay? And they also have some other injuries, so they have a distal radius fracture as well. And so these are their x-rays. Once you get those in the emergency department, I don't think there's any clinical photos on here, but does someone want to give a shot at describing this one?
I gotta just say what it looks like. We won't be too harsh. Here we go. Christian, you got it, man. Go for it.
All right.
The Buckeyes.
So I see a AP lateral, and then I think that's an attempt at a mortise view. It looks like a right ankle, skeletally mature adult. I see a comminuted, little bit higher fibular fracture, also a medial malleolus fracture, and then maybe looks like some type of a posterior malleolus fracture as well, and then pretty significant dislocation of the talus laterally relative to the tibia there.
Great. How do you do, Seth?
I love it. If you had to classify that, what would you think? So don't even think about back to that screen with all the information on it. Just think about the way that that ankle must have moved, or maybe the position that it's still sitting in, and maybe kind of the condition of the fibula.
Yeah, I definitely think that the foot looks abducted, so I'm going to go with pronation abduction.
Yeah, love it. So that you're not, that's not a rotational. You can't see my mouse anymore. I'm pretending that you can, but that's not a rotational fibula that you expect to see. That's one that got crunched all at once. So the comminution and then a bending mechanism. So I agree with pronation abduction.
Good job.
Nice.
You'll often also see that lateral plafond impaction or knock fragments off with that, carry fragments laterally with the talus. And so those free fragments in between, exactly, that represents impaction that may need to be dealt with.
Yeah.
So this is your chance to be a hero in the ER. You know, you have this person with this awful ankle deformity and they're in serious pain. And Max, what happens when you put the ankle block in and you reduce them? It's a little different feeling, isn't it?
Yeah, you kind of feel like a rock star.
Yeah, this is what makes ortho fun. You know, we talked about posterior tibial tendon insufficiency and FAI and stuff like this, but this is really where ortho gets its reputation, and this is what really draws people to orthopedics is fixing trauma.
Well, I mean, for some, it's taking down cam lesions too. So you know, I think you gotta figure out what works for you. But
nothing burning for an hour just to get an X-ray.
Yeah. So this is post-reduction x-rays, so same three views and a splint there. And so they were signed up for surgery, and this is what they ended up getting. I think this was one from this week, I think. So a little bit different kind of construct, but also very similar. So you could see fibula is fixed again out to length, but due to a lot of that comminution, the plate's applied in a little bit of a different mode.
Extra credit, Christian. If the first one was more of a compression style plating, what do you think this one, or more of a buttress? What do you think this one is?
This looks like a bridge plate.
No. Nice.
Right.
That's
Nice.
awesome.
So also has the syndesmotic screw. placed in a little bit different spot relative to the fibular plate, but it's doing the same thing function-wise. And then this person got 2 medial mal screws compared to the last one that just had 1. So I think, again, restored alignment, if you look at the mortise, it's, symmetric all the way around is what you'd want to see. So hopefully this person is set up to have a pretty good outcome with the surgery here. So
that plate looks a little thicker than the previous plate. Is it stacked?
no comment from me. Maybe it is. Might be.
I don't know.
Wasn't there.
1/3 tubular is a bridge. Okay.
Yeah. Next one. So 23-year-old. They are a construction worker. They fell off of a roof about 10 feet high. Otherwise healthy. No medical problems or significant medical history that could be contributory. So these are x-rays of his ankle. Get a little bit of help from your radiology folks there with a big arrow sign. Who wants to give this one a shot?
I see Ashraf. I think it's great that you got video of all these injuries, Max or Eric. It's really nice that you were able to do that. The guy falling off the roof and the guy falling off the porch. All right, Ash, it's you, man. Go ahead, describe it.
Yes, sir. So on the AP, we see a lateral fracture consistent with a Weber B, and we have a medial clear space enlargement, indicating a lateral Taylor shift.
Very good.
All right. Want to give a shot at throwing it into one of those classifications? What do you think?
I would go for supination external rotation.
Yeah, I think I agree with that. Yeah.
When in doubt,
Love
SER
it.
is a good place to go.
Yep.
Yep.
Ash, why don't you tell everybody what time it is where you are?
It's no big deal. It's like 3:30.
Nice.
PM or AM?
Yeah, nothing to start the day like ankle fractures.
Nice. Good job.
So to you or to anybody else, what's the difference in this and the ankle fracture that we said was an SER that had a little bit of medial clear space widening that we treated successfully in a cast during the lecture? Are there any differences between this X-ray and, I don't know if you remember the example I showed where we showed the gravity stress view and then we put it in a cast and everything lined back up?
I think here this indicates that the deltoid ligament is not intact.
Yes, there's a lot more fibular displacement, and then there's just clear, overt, more severe widening of the medial clear space. So this is not subtle. This is one that you would you don't need a gravity stress view for because it's already positive. It's already displaced. So that alignment is not going to result in a low risk of arthritis. That alignment, if left alone, would do very poorly. So that's one that would get surgery. Yeah, good job.
Yeah, so reduction x-rays there. And so you can see we've got the talus back under the mortise. It looks a little bit more normal as far as alignment goes. And so like Dr. Yarboro said, given the pattern and the amount of displacement there, so they ended up getting a surgery, and they were fixed with just a fibular plate that you can see there. And so there's a screw in the middle of it. That middle screw is kind of acting as a lag screw across that fracture, also going through the plate as well. So you can see that x-rays aren't the best as far as having a nice clean mortise just from a radiograph standpoint, but you can see how everything's again lined up and anatomic. So again, hopefully setting this person up to do well as well as far as healing goes. Next one. So a little bit different patient here. So they a little bit older, so 65 years old. they're in a motor vehicle accident after having a stroke back in June. And so they had been, after their accident, up walking around, putting weight on the ankle prior to us being involved and us being notified of what was going on. So, so they're the ankles you get, let's see, 4 days after the car accident. So anyone want to describe those?
Anybody want to raise your hand? I don't know. All right, Molly, go for it, bud.
Okay, so we have a AP, a mortise, and a lateral of the left ankle of a skeletally mature individual. I think I see a distal fibular fracture starting at the joint and extending up. So I would call this a Weber B. I think it's isolated. I don't see any other fractures in the view.
Yeah, I agree with that. I think, you know, so a little bit older patients, so they might not have the best bone to see fractures, you know, if they're a little osteopenic, whatever it may be. A lot of times I'll look at the lateral, and that can help you a lot. And so I think this one is fairly telling as far as what kind of fracture they have. So if you look on the lateral, you can see that fracture line starting down anteriorly, inferiorly, and starts progressing up and kind of exits posterior superiorly, which is a kind of a classic pattern for a kind of a typical Weber B fibular fracture, particularly in an SCR pattern. So, so good job. And so they were treated. Oops, sorry. So they eventually got weight-bearing X-rays. Okay, so these are the weight-bearing films. And can you describe anything different between the two, Molly, do you think? Or do you think they look pretty similar? What do you think?
I think there may be some widening in the syndesmosis in the mortise view.
You think so? So there
Yeah.
compared to there, I'd say they look pretty similar. Where would you be looking if you're looking for widening?
I guess right at the joint
Yeah.
line you'd normally be looking.
Yeah, there's a bunch of different areas you can look that are described and with different numbers that are normal and what is considered abnormal. I think the easiest place to look is right here along the medial aspect of the ankle joint.
Okay.
So in general, if you've got good x-rays, this should all be about that same width, the clear space, okay? And so if they have a significant injury like the x-ray we saw before, you can tell the difference, this width compared to that. So clearly wide there. Over here, I would say looks pretty good. So they've got physiologic loading of their ankle and the syndesmosis itself with weight bearing. And I wouldn't say they've widened very much at all. So this is one that doesn't necessarily need a surgery because the ankle is stable. So we're not worried about altered tibio-talar mechanics or joint loading. So this one was treated with a fixed ankle walker, and they were allowed to weight bear in it. So.
Well, also, you think about it, this person walked around for 4 days prior to presentation, so they've already stressed this joint pretty well, and they still haven't displaced. Yeah. That's another important thing to think about.
Yeah. Nice job.
I think we can wrap it up. I think we got to get to the research aspect of this, although
perfect.
I like your video here too.
Yeah, no, sounds good.
Awesome job, Max. Great job, everybody answered questions. Yeah, half of orthopedics is trying to understand the x-rays and read the x-rays. And so learning that nomenclature is really important. So great job, everybody who answered. Michelle, are you out there? Can you share your screen? Nicole just texted me. Her patient's still intubated in the operating room. So
Yeah, that's fine. I don't mind doing her talk.
does our night float team not pitch in? What's happening here?
I'm just texting something along those lines because the day team today has a day with me tomorrow.
I know.
And I want them in good shape.
Get those people home.
All right, so Nicole, one of our PGY4s, put this talk together, but I figured I would help her out since she's still operating. So she had a talk on orthopedic research in our department. So she tried to stay true to her intentions for this talk, but so she started off with the description of kind of the wide variety of opportunities in our department. Each service has a very robust research group. As you can see, they're all listed there, and they all kind of encompass all these different research scenarios. So we have clinical outcomes research, especially database kind of driven. We belong to one big the database that we've mined for the last couple of years and had a fairly robust output from that particular database. We also have some basic science labs that are run by a few of our attendings, as well as some great research that's, we have some partners that we do research with. And then additionally, we're also involved in some larger randomized controlled trials with other institutions across the country. So we really encompass all different kinds of opportunities here at UVA. And so in order to accomplish this, we have research grand rounds, which are typically monthly meetings. Each service has their own meeting in a different location, but they're all at the same time on Wednesday mornings. There are all the attendings in that service, as well as the research coordinators and any residents who are interested or medical students who are interested attend these meetings. And they, at least I go to the sports one, that's what I'm interested in. So they kind of have a list of all the active projects and all the active clinical trials, and they go through each project and everyone speaks up and says how the project is going, any issues or any progress in the project, as well as any submissions or publications. That's also an opportunity to discuss new ideas. So our attendings are very supportive of any idea that you have. They'll either support you within our department, or if you have an idea that you'd like to collaborate with the engineering department or biomedical engineering or any biomedical, biomechanical research. We have lots of collaborators that we work with on a daily basis, and they're able to make those connections for you if you have any ideas that you'd like to proceed with. So we are very focused on research. So we have a council that actually kind of guides our department in how we want to approach research. So it's made up of several very important people. So Dr. Chhabra is our chairman, obviously, and so he heads the council. Dr. James Brown is one of our joint surgeons, and he's very involved, especially in clinical outcomes research in the total joints world. Dr. Quay is also one of our joint surgeons. He's has a basic science lab, which I'll talk about in a little bit. Dr. Christ is one of our collaborators. He also has a basic science lab that we collaborate with. Sean Russell is one of our biomechanical research partners, and so he has his own biomechanical research lab that we occasionally partner with as well. And then Dr. Hart is more clinical research. We work with him a lot in the sports department with clinical outcomes, especially after ACL reconstructions. So like I said, this is our kind of our core basic science group here. So Dr. Chris on the left, he has a lab of regenerative medicine and tissue engineering technologies, and he works in developing new biomaterials. Dr. Quay's lab, like I said, is one of our total joint surgeons. He works primarily in stem cell therapy for MSK diseases, as well as development of bone graft substitutes. And then he's very interested in osteoporosis of the femoral head, so he works a lot with AVN. And then Dr. Lee is one of our spine surgeons, one of our former residents who now came back on faculty. He works a lot with intervertebral disc degeneration, as well as stem cell treatments and nanotechnology and gene therapy for spinal pathologies. Any residents who are interested in any basic science, they're welcome to approach these attendings, and they're very happy to have you in the lab if we have time to fit into our schedules. We also work with exercise and sports injury laboratory, especially on the sports department. We have a post ACL kind of return to play test that we've done a lot of research with recently, and outcomes after ACL. There's also a motion analysis lab if you have any interest in, as you can see down there, in rock climbing or any really motion analysis or motor performance in any sports. Or I know one of our former residents did a kind of baseball study with biomechanics in that laboratory. And then we also have clinical trials research if you want to be involved in kind of bigger scale projects. And as residents, like I said earlier, we're always supported in our endeavors. We're encouraged to submit abstracts for both regional and national conferences. And if we are accepted to these conferences, the department does help us pay our way. We have a fund which we are able to access for conference attendance, especially if we have a podium talk presented. The department will fund your travel and your stay at the conference. And all the chiefs attend the academy meeting every year. And anybody who has a talk at the academy also gets to attend. And so I was able to go as the PGY-3, and that was a great experience. That was my first academy, and it was really fun to see what that's all about. It's an enormous meeting, and you get to hang out with the chiefs, kind of a more informal environment, as well as the attendings who attend. And so going to meetings is great. I've been to kind of regional meetings, smaller ones, kind of around Virginia, and then of course the academy is the much bigger meeting. And so our department's very supportive of any residents who get any podium talks. I think we've tried to limit international travel. One of our old chiefs had some significant international travel, but I think that's, we're doing more kind of national meetings these days. We also have Resident Research Day every year. It's part of our graduation week celebration. So it's, we have a guest speaker, which is the graduation speaker. They usually present 2 talks on that day, and then all the residents present one project that they've worked on over that last year. So it gives them an opportunity to share research and kind of be judged and practice on how to give a podium presentation to a panel of judges. You get questions afterwards from the panel, and then one winner is chosen by the panel and then also announced at graduation. So this is, Nicole included kind of a list of our talks from this past graduation. So the top 5 are our chiefs, and then it kind of goes down by class. So the PGY-4s and 5s are on this slide. You can see we kind of run the gamut of all kinds of different projects. So all different specialties, as well as all different types. So you can see Mike Hadid had a gait analysis lab. Harrison Mahan had kind of more outcomes research. Dennis had some kind of database research. Trent even had some basic science he pulled out from medical school. So they really comes from all different all different types of research. And then this is kind of completing the list here with our current PGY-4s and PGY-3s. And you can see all the different variety of projects that we were able to accomplish in 1 year as a resident. And so in conclusion, you can be as involved in research as you like. I know some people want to do 1 project per year, and I know some people do a ton of projects a year. It just depends on what your interests are and how involved you want to be in research. We are expected to have 1 project per year, which you present at Resident Research Day. And you're able to present in all different types of projects. So I've done research in peds, in trauma, in joints, and in sports, and I'm going into sports. So anyone's really happy to have your help if you're interested. And you can be in as many projects as you want or as few as you want, but there's always opportunities and encouragement if you have any ideas, if you want to get involved. And this is Nicole's talk. So this is the current PGY-4 class on the right. And this is one of her favorite hikes here on the left.
Thank you, that was great. Michelle, so just a thought on research as a program director. You know, some people come to residency wanting to be part of research projects, and I applaud you for that. Some people just want to learn to be orthopedic surgeons. I also applaud you for that. I don't think we're going to shove research down your throats here at UVA, but we want to make sure we provide you the resources to be successful. Ultimately, being in orthopedic research helps you understand kind of the concepts you're trying to learn, and I think that contributing to the betterment of what we do is actually a really important thing. And so we do have a robust research program here, and I do think we have expectations that residents who come here do research. We've had some who've graduated with very little research experience, and that's fine. It's just we want to make sure that we allow residents who are interested in research to have those opportunities. So when you apply for fellowships, and Michelle can tell you, she did really good applying to sports with her research portfolio that she had. You know, she had a CV that would compete with junior faculty at different places. And so you do have the opportunity here to be productive and, you know, put yourself down on paper and the opportunity to present at national meetings, get your name out there. So that's kind of my thoughts on that. And if anybody has more interest in the research program here, please contact me and I can put you in touch with Dr. Quee or Dr. Lee or Dr. Hart or those people who do the research here, okay? So with that, it's 8:55. It's actually kind of sad. Our first session's pretty much over. You know, next week we're going to do just a resident town hall kind of situation. So I'm going to try to recruit some residents to come out here and chat with you all. But it's been fun. I hope you guys got a lot out of this. You know, I got a lot out of this just kind of talking to all of you all. And actually, for me, listening to the different faculty do their talks was really kind of cool. listening to ankle fractures. I mean, honestly, I don't think I ever understood ankle fractures. It's quite the way Dr. Yarborough just described them. So I am going to send kind of a post-mortem, like basically a survey after all this, kind of get your thoughts on how this process worked, because we're actually have another session coming up. And to put it in perspective, this session had 19 registered, our next session has 45. So I got to figure out some way to navigate that. So I want to say thank you to Dr. Yarborough, Dr. Hoggard. Those are outstanding. I mean, you guys did an awesome job putting that together. And are there any other questions from the crowd before I close? Because next week I'll probably just turn it over to the residents. So you probably won't hear me talking much more. Again, you can email me. You all have my email. I've been emailing you every single week. I'll send you a YouTube link to this video, and then please keep in touch. You know, this is a strange year, and I feel bad for everybody going through this process during a transition year in your life. I mean, it's hard enough for those of us who have established jobs, but I can't imagine what it must be like to be somebody who's kind of in a job interview phase of your life, not being able to go into the places you might end up having a residency spot for 5 years, or meet the actual faculty you might be working with, the residents you'll be working with. So I really feel bad about this year. I hope that we were able to give you some level of just involvement and engagement in our department during this process. So with that, I think I'm done. Dr. Bachman, do you have anything else to add? Keith? All right.
I'm here. I got nothing to add.
Your picture always looks so funny because it looks like you're about to talk, but it's just a photograph. I think we might need to get a new photo of your.
I love it. It's perfect.
It's perfect. I wish I could grow a beard like that. Awesome. Well, thank you, everybody, and we'll see you next time. Please keep in touch.
Thank you, guys. Thanks to all the participants.
Thank you, Seth. Thank you, Max. Thank you, Michelle. All right. See you later, guys.